Right, good evening, everyone. Sorry, good evening, good afternoon. The lighting in this room feels like permanent evening, but yes, hopefully we'll actually even finish the meeting before it's evening. So, welcome to this joint Leicestershire and Rutland Health Scrutiny Committee. This meeting is being broadcast live to the public via YouTube and will be available for viewing on the YouTube channel after the meeting. Please turn your microphone on and off when you're speaking. Anyone not familiar with the County Council system, too many red lights on the system like this one here, and the whole system slightly comes to a halt. So when you speak, press the button. When you finish speaking, if you press the button again, and then it works pretty well. Likewise for any of our guests today as well. Also, there are several new members to the committee, so I'd like to welcome all of you. Also, the agenda pack has a slight change. We've got Councillor Shahruz, welcome. You're replacing Councillor Kittrick, sorry, apologies. And anyone in this committee knows that my ability to pronounce anything is pretty limited, so apologies. As a permanent change for Councillor Kittrick, so welcome and thank you for joining us. And likewise, welcome to Councillor Ross from Rutland, Councillor Bonham as well from the city. And we also have from my vice chair, who's Councillor Whittle, indeed, and from the County Council, we have Councillor Mrs. Seaton, Mr. Harrison, and Mrs. Newton. So thank you very much. We have a couple of members who hopefully will still be joining us as the meeting goes on. We've got a couple of apologies, one from Mr. Hills, who unfortunately is not very well, and likewise from Councillor Wesley, but hopefully there'll be a couple of more people who will be able to join us as the meeting progresses. So let's get on with the meeting. As usual, we'll try and target 2 hours, which I think is a pretty good target for any meeting. Likewise, that means that we'll be taking all papers as read, but I'll ask anyone introducing their paper to summarise or draw our attention to any of the key points for a couple of minutes prior to opening discussion and questions. But otherwise, we'll move on with the agenda items. So agenda item 1, which is the minutes of the previous meeting, that was held on the 6th of February 2023 at City Hall. Can I please take that as read? Thank you very much, Mr. Harrison and Mrs. Newton. So we'll agree those. Item 2, question time. Haven't received any questions from the public. Likewise, question 3, haven't received any questions from members. Item 4, there are no urgent items. Items 5, declarations of interest. Are there any declarations of interest that anyone wishes to make? Mrs. Newton?
My son works for the NHS, and as does my daughter. She's the clinical commissioning nurse, so I'd like to make those declarations of interest. Thank you, Chair.
Thank you very much. I'll also make one under item 9, which references mental health cafes, and my wife is actually a trustee of a mental health charity in Loughborough, which provides a drop-in cafe, mental health cafe. Mrs. E.
Sorry, I didn't realise I had to declare an interest. So my daughter works as a sister at the NHS.
Thank you very much. Okay, no more further declarations. So we now move on to item 6, which is the presentation of petitions. There are no petitions, which leads us on to the main 4 items of the meeting. The first one is the NHS Leicester, Leicestershire and Rutland Integrated Care Board Plan, 5-year plan. We're with us Sarah Prima, who's the Chief Strategy Officer at the ICB, and also I believe Amit Shamni, who's here to join as well. So I think unless you have any additional slides that you were going to present, I think you have distributed your pack. So we've had the full pack of presentation slides, which we'll obviously be able to make reference to, and also likewise your 5-year plan report, which was great to receive and read. Thank you very much for that. Now, if you would like to highlight any particular points in either the presentation pack or the 5-year plan, that would be great. And then we can hopefully go on to questions and any other points that people want to make. So over to you.
Thank you. I'm just going to do a quick introduction, and then Amit's going to just go briefly through the slides with you, because that will give a bit of context. So ICBs came into existence in July 2022 as part of the requirement, the statutory requirement of ICBs. We were to develop a 5-year plan, and any good organisation needs a decent strategic plan. So this is the development of that strategic. It was developed from about July last year through to the middle part of this year, and involved all of our partners and insights from the public, and is based around a number of pledges and a number of key focus areas, which I'm just going to hand over to Amit just to take you through a little bit more detail. Thank you.
Thank you, Sarah. So just to continue from what Sarah said, the plan which you've got in your packs is built on a set of pledges we make to the residents and populations across LL and R. And I just want to focus in on those pledges because they are the core of the plan. So that on your packs is slide 115 within your plaques, which is your first set of pledges. So there's 13 pledges in total. They are all of equal importance. The first pledge we make is around health equity, or addressing health inequalities. Addressing health inequalities is one of the core purposes of why integrated care systems were established. It's also the golden thread which runs through the entirety of the plan. So there's a specific pledge there around improving the health of our most deprived communities and trying to narrow the gap between those who have the best health outcomes and those who have the worst health outcomes. Pledge 2 is around prevention. So usually the NHS is perhaps seen as more of a sickness service. We deal with ill health and disease, and we perhaps have less of a focus on prevention or preventing ill health. The NHS long-term plan from 5 years ago tried to refocus some of that attention onto prevention. If we look at the 3 biggest causes of premature mortality in LLR, so what kills our residents earlier than when they should, they are cardiovascular disease, they are respiratory disease, and they are cancer. Now, all 3 of those have key modifiable behaviours, be it around smoking or diet or exercise, which we with our partners need to do more on in terms of preventing ill health in order to have a sustainable healthcare system going forward. Pledge 3 is in recognition, as much as we can do within that prevention arena. We have a significant number of our residents who have a long-term condition or multiple long-term conditions. So we therefore must be better at identifying those patients, optimising their treatment, and trying to make sure they live a healthier life as possible for as long as possible. Pledge 4, 5 and 6 are perhaps the pledges which will resonate most with our residents across LLR, and our engagement and insights show us this. So if we walk down a street in LLR and asked a member of the public what mattered to them from a health perspective, invariably it will be access to a GP or a GP appointment. It will be an ambulance arriving in a suitable time for when one is dispatched, and then being seen in a timely fashion within the A&E department. So those 3 pledges are making sure we deliver the right care at the right time. We have made significant inroads on all 3 of those, but there is more work to do. Pledge 7 is perhaps at the heart of integrated care systems. So how do we ensure we are delivering genuinely joined up care? Some of the feedback we get from our patients and residents is they can sometimes feel that their care is fragmented, and something called storytelling fatigue, where they're having to repeat their stories. We also hear, equally around that desire to receive more care closer to home. So Pledge 7 around establishing these health and wellbeing hubs talks to the desire to try and deliver more joined up care closer to home. Moving on to the next slide, so 116 within your packs. Pledge 8 is around elective care. So we know we have challenges in terms of patients waiting for surgeries and operations locally and nationally. Although we've made some good progress in some of our longest waiting patients, there is more to do on that particular work programme. So there's a specific pledge there. Pledge 9 is around learning disabilities and autism. So our local data shows us someone living with a learning disability or autism will have a life expectancy on average 20 to 25 years less than someone who doesn't. We've established a learning disabilities and autism collaborative, so a partnership of members across health and care to continue to do work around learning disabilities and making sure those patients receive health checks and action plans to support them. Pledge 10 is around mental health, so making sure we maintain that parity of esteem between physical health and mental health. Pledge 11 is around children and young people. So if I go back to Pledge 8 around the waiting list, we know we've got challenges in terms of children waiting to be seen by a specialist and receive a diagnosis and therefore commence treatment. So there's a specific pledge around children and young people's. Pledge 12 is around women's health, including maternity. So if you look at the Ockenden review, which looked at maternal care and deaths, one of the key findings from that report was the importance of listening to women. It was echoed again in the government's women's health strategy, the importance of co-designing and empowering women to design services. So there's a specific pledge around that. The final pledge is around our people. So the NHS greatest asset is its people. We have significant challenges locally and nationally around retention, around recruitment, around morale, around burnout. That has knock-on consequences in terms of financial position due to a reliance on agency staff. We're starting to see some of the burnout and morale through the industrial action. So there's a specific pledge there around how do we make LLR a desirable place to work where staff are rewarded and recognised and ensuring we've got a workforce which meets the future needs of the population of LLR. So the plan is built across those 13 pledges. I'll just scroll down my slides 1 second. This is on slide 118 now, just in terms of how the plan is structured. So the plan is structured through a set of interventions which help us deliver those key pledges. Each of the areas has a dedicated forum to oversee the delivery and implementation of those interventions. So, for example, the Learning Disability and Autism Pledge has a set of interventions which will be championed and driven by the Learning Disabilities and Autism Collaborative. We also have an outcomes framework. So it's all well and good making these pledges. We've also got an outcomes framework which contains a number of metrics which we will measure to demonstrate we are delivering against that specific pledge. The focus now is clearly on delivery. That's where our focus needs to be. If I scroll down to the next slide, which is 119 in your packs, we were required to ensure that the 5-year plan reflected and respected the 3 joint health and wellbeing strategies across our 3 places, city, county and Rutland, and we were required to work closely with those respective boards, and we did require a statement of support or a statement of opinion from those 3 boards, which we've obtained, and that's contained within the plan. The next bit of focus now is again around delivery. We have got a little bit of work going on in terms of how do we make sure we continue to champion the plan and inform our residents and public around our progress against the plan. So you'll see some more stuff coming out through our comms teams, through social media channels and so forth. That's all I wanted to add. Sarah, did you want to add anything more?
No, that's fine. Take questions.
Brilliant. Thank you very much for that, and thank you very much for bringing the 5-year plan to us. Can I ask one quick opening question? I mean, clearly this is a plan that I'm assuming every single ICB needs to do nationally, and there's a huge amount. Not only you referenced the sort of connecting in with the 3 plans locally, but also nationally with the NHS's plan and targets. It's really the LRR part of the plan, which obviously we're probably going to be drawn to, which is actually the bits that are particular to us, you know, that make this plan relevant to residents locally, that for us as councillors, you know, where are the connections with our particular needs. One of the areas that I know is drawn out within the report is areas of deprivation. and there's obviously a significant difference between the needs in the city compared to Rutland. I mean, I think it's 130,000 people potentially, is it, in the city, and there's 169, I think, in Rutland. So I mean, the difference between those two areas is extraordinary. It's somewhere in between for the county areas, and I just wonder how do you actually, given that there are very distinct needs for those three areas, how does the plan manage to actually accommodate that? What have you actually done within the plan that means that it is particular to our areas and therefore relevant to our residents?
So I think there's a couple of things I'd say around that. First of all, that it's about delivery. So as Amit talked about earlier, the three highest causes of premature death are still the same in each of those areas. Actually, there is no difference in that, but it affects different people in different ways in different communities. So it is actually about then how do you deliver it in different places, and the nuances about how do you deliver things. So a lot of it is in the delivery. So we may say, okay, we're going to do cancer screening in all areas, but how we deliver it in Rutland with a very rural population, to how we deliver it in the city with a very urban population with those high levels of deprivation and some of the cultural issues around screening, to how would you deliver it in the county with its widespread communities and market towns, is the key, really. So the core things, I would say, the core pledges are important to most areas across LLR, but it's then about how you deliver. And I think there is also something important about, we're not trying to go to the lowest denominator. So we still need to keep investment and standards up in each place. It's about how do we invest extra money or extra resources to try and reduce that gap.
Thank you very much. Mr. Harrison.
Thank you, Mr. Chairman. Yes, thanks for the report. It's very informative, lots of numbers, bells and whistles. Our role is to dig down, drill a little bit to try and understand it better. You're saying from April, you reduced by 7,118 to 133,514. We hear today nationally it's 7.7 million. I guess these figures have gone up since then. But what I'm interested in at this stage is to understand people waiting for what? We ought to know. Is it eye? Is it cancers? Is it broken bones? What are the people waiting for? Because when we talk to the public, they're telling us all sorts of different complaints, but we never have a view to it. So is one area a bigger waiting area than others? So we can understand, because then it stands out that little bit further. So I think that would be really helpful. I also would like to ask absenteeism. Every employer has absenteeism. It's just how, people are not well or whatever, or they become ill and they're off for periods of time and everything else. I mean, I'm not talking industrial at the minute, because that will have a bad impact, sadly, for everybody. But it's important that we understand this. So if we know what particular aspect of illness and how many is on a waiting list, because they're not all going to be, you can't divide that by 10, 20, 30 and everybody's equal. There's going to be some groups of larger consequence, and it's trying to understand from our point of view how that really actually works. And then obviously absenteeism. We'd like to know where it is. Is it a radiologist? So that can throw everybody out for a day if you're short and you can't have x-rays from casualty or whatever. So it's just trying to understand what the baseline in the picture is. So that would be helpful to be able to understand that picture. Moving on to mental health, it's pleasing to see Leicestershire significantly better than the England percentage of schools, but how sad I am about the city. That's not a good result. and across are the long waits, fragmentation, support offers, and a whole range of things. So I'm really interested to understand what your thoughts and views are regarding that, because unless you've got a strategy that's going to tackle it, it'll be the same for your next provision. And it goes on and goes on. Looking at your delivery plan, urgent and emergency care partnership, and there's various bits listed there. I'm beginning to understand a little bit about that and how all of this comes together, which is really important and relevant. I'm also concerned very much about Chapter 6, finance, because I can remember on this committee maybe 6, 9, 12 months ago, the chief executive and the new finance director told us that there was 70 million suddenly discovered, black hole. Then they went a bit further, it was 80 million. I mean, you're talking of 150 million. So I was astonished and told, no, the government's wiped that out. Oh, lucky for you. I was wondering how you're going to manage to be able to cope with all of that debt. But looking at it and going through the figures, you're still in a precarious position because you are looking at going forward and position of quite considerable losses. And I really would like to understand that a little bit more, because we also include the efficiency challenges. So it's a full scale of financial challenge over the next 5 years is 380 million. There's some big numbers here that's got to be drilled down to understand. Now, maybe you could sit with a wry smile and say, well, don't worry, council, the government will write it off. Now, I'm not sure how compassionate they'll continually to be if we're not running an efficient business. So I am concerned because some of these numbers, I don't want to drill it all out here now, but there is problems. And, you know, as I say, your explanation you went through, but you just seem to skip past the finance in any real discussion or depth, if not at all. So that concerns me. And I think if your basis isn't right, so what I'm saying is, and you mention efficiency in here, I would highly recommend you have an efficiency review externally, not internally, because a lot of these people, sort of organisations say, yeah, we'll set that up. But it's not the same. You need external because they're professional, they understand flows, etc., etc. So good report, full, and it's on the table. But when you start to drill down, it's not so happy. There's some real issues that need to be looked at to explore. And hopefully, if you are able to then think of an efficiency outside external body to come in and just review, because when you're in a big organisation as yours with formalities and procedures, we always do it this way. Why do you do it that way? Well, no, we always do it this way. So there could be an opening here. And I think any organisation that's going to carry on with the best part of 200 billion from the taxpayer, we know we've got, I know the waiting lists are a gradual progression over a period of time. This isn't last week or last year. And I know the present incumbents inherited a real nightmare scenario. There's no doubt about that. But hey, it's your nightmare now, so you've got to deal with it and move forward. So those are my thoughts, Mr. Chairman. I'd be happy to listen to the response. Thank you.
So I'll just take the waiting times as the first topic. Waiting times are generally across a number of specialties. There are some specialties that struggle more than others, particularly from availability of expertise. But this did come up last week, I think, in the county HOSC as well. So I'm wondering whether you'd want to have this as a topic in a future meeting, actually, because it's come up a couple of times now. So I could get somebody from the organisation that knows a lot more detail around the waiting times than I do to come and give that explanation. But generally, it's across most specialties, but some specialties are experiences a higher backlog than others because of availability of expertise, etc. Absentee rates, I think that was, I think what you meant by that is, do waiting times get affected by the staff being absent? So we could probably cover that in the same in the same presentation. Mental health waiting times, I think that the mental health sector, so we've been doing a big transformation program around mental health, covering right from community through to acute mental health services. So and also we have to make sure that we keep what is called the mental health investment standard at the right level, which is a programme that the government brought in a number of years ago to do exactly what Amit said, which was to make sure that mental health spending was on par with physical health spending. So the plans in this strategy are based on quite a considerable amount of work that have been done through our mental health partnership to look at what needs to be transformed over the next few years in order to make sure that mental health services are at the optimum. In terms of finance, we are in the process. I'm not going to hide from the fact that finance is tricky. It's tricky for most public sector organisations. We'd all like more money than we've got, but we have to manage within the resources that we have. We are just about to finalise a medium-term financial plan, which I think might be helpful to come here as well, actually. And as part of that, we will be looking at those efficiencies. So each year we will look at, as we go through our planning round, we will look at the efficiencies. We will use benchmarking data. We do have external reports and organisations come in and have a look. We're also heavily scrutinised by NHSC regionally, who again support us on things like benchmarking and efficiency plans, etc. So I think there's a number of things around finance. It's not easy. Finance is tricky for us all. But as we develop the medium-term financial plan, we will review where we are financially and how as well.
Roughly, when is the medium-term plan?
It should be the autumn. It should be the autumn.
Okay, so maybe it will come to the December.
December, yeah.
Yeah, okay, that'd be useful.
Thank you for your response. I would really urge you to look at external efficiency review, because your words were just what I've heard before many times. You've got to have external who come in with a clear, open mind, and it's not, you're doing your own homework all the time, because where you are is where you are, and if you're not careful, it will be catastrophic. And those numbers in there are quite significant. I can see your first low number and inflation and all sorts. I get all of that, but there's some real deep problems that you've got to arrest, and the sooner you get into that, the better. Thank you, Mr. Chairman.
Thank you, Mr. Harrison. Mrs. Newton.
Thank you very much. I've had as good a look at the plan as I could, and thank you for all the work that's been put into it. You have highlighted quite a number of the challenges, including around access and primary care and hospitals, especially in the mental health area. And I just wondered whether or not, how good is the joint working across all agencies to try and alleviate some of the problems you have with people presenting with mental health problems? Because I think that there is a lot of scope for really good joint work on this. Thank you, Chair.
Thank you for the question. A key question, and we know we have challenges around mental health. What we've done, and not just within mental health, but across all of the areas, is we have established partnerships. So we have a dedicated mental health partnership, which brings together partners from LPT, from primary care, GP practices, and also local authority and public health colleagues. And that partnership is all members involved within our LLR system interested or delivering mental health services. I believe they also have representation from the individual health and wellbeing boards as well, health and wellbeing boards. going one step further, so there's a partnership which operates at a system level across LLR. We also then have 3 further partnerships, so one for city, one for Rutland and one for county, because we recognise the challenges across the 3 places are very different, be it for geographical reasons or deprivation reasons and so forth. So we feel the correct infrastructure in terms of the right partners sat around the right tables having the right conversation. So I don't feel too concerned around have we got the right partners, or are we approaching it in an integrated way? One thing we are trying to do further now is try to bring in further insights and engagement, because we can sit in a room and try and plan services, but what really matters is hearing from the people receiving those services. So what we've done throughout the plan across all chapter areas is we've tried to look back at all of the engagement exercises we've done. So we've did a specific one around mental health about a year or 2 ago, Step Up to Great Mental Health, which was a consultation we ran across LLR, and we've tried to take those findings into the partnership so it gives them something to work to. Thank you.
Thank you very much. So I've got Councillor Whistle next. Councillor Ross, did you want to speak afterwards?
I want to follow up first of all on the comment.
No. We'll take you in order, but if you want to, anyone who wants to speak, if they catch my eye, and I'll add you to the list, and then we'll call in sequence. It's not that sophisticated, unfortunately. Tends to fall over if everyone starts pressing the buttons. Councillor Whistle.
Thank you.
Didn't work. Right. Okay. I was looking for more information on the figures for the elective care waiting lists. In particular, how much elective care has actually been delivered. Because, for example, what we saw with GP waiting lists is, although the number of appointments was increasing, the waiting lists were increasing also, which showed that demand was outpacing the additional resources that were being made available. I've also seen a report that suggested that although resources have been put into reducing the waiting lists, the amount of elective care being delivered was still less than what was being delivered in 2019 before the COVID pandemic. So we might not get what we want to see from those figures. I also wanted some breakdown of some granularity of the figures. It was mentioned that a number of different services are involved, but I'd like some idea of how they're being prioritised. I mean, who are the people that are really suffering from these delays, and who are the people for whom the wait is, obviously all delays cause stress and etc., but obviously for some people it's much more serious than for others. Moving on from that, as far as the picture of the finance goes, I agree. I'd like to see a bit more detail of those figures. They're very large numbers, and it's very hard to really understand. I mean, I used to manage a budget for 50 million a year, and that's just 1/40th of this. So it's chicken feed in comparison. That was difficult enough. What I wonder is whether these figures give us a picture of how much the income of the authority of the ICB overall has been adjusted for inflation year on year. And we do understand that in the health service, inflation is higher than in other parts of the economy. And secondly, I wonder how much we take account of population growth. For ballpark figures, I understand that the population across Leicester, Leicestershire and Rutland has grown by 10% over the last decade. So how much are we anticipating growth over the 5 years of this plan? So I do think we need to take that into account, because clearly over the last decade, the proportion of the gross domestic product of this country which is invested in healthcare has decreased quite substantially. Again, looking at the waiting list for elective care, there is a very substantial cost benefit on getting those figures down. Huge numbers of days, productive working days, are lost because people can't work because they're waiting for surgery or some other treatments. So, you know, I think I would just like to add my support to this being the most important area where we need to see improvement. The last question I would just like to ask about is the UHL reconfiguration plan. Do we have any up-to-date information about that? I understand that the original cost envelope of £450 million that was allocated for this work, obviously with inflation, that figure should now be well over 500 million if the original scheme of work is still going to take place. Do we have any information about whether that's original? Right, okay. Thank you for that.
Just for councillors' benefit, the reconfiguration plan was going to come to this meeting. It's now coming to the December one because I think it's going to the main board before it comes to us. So it's absolutely, we do need it here and it will come here.
Yeah.
Sorry, can I go back to?
What I'll do is I'll add Councillor Whittle's comments into those of Councillor Harrison's, and well, when we bring back those two papers, we'll make sure. The thing about I'll just make one point about growth. There is a national formula about how NHS money is distributed across ICBs effectively as we are now, and that does include growth. It's a very complicated formula. I wouldn't admit to understand it myself, but it does include growth. But we might touch on that when we bring the finance paper back. And I was just going to say, you know, UHL will be asked to toe the Thank you.
I mean, the other points on elective care and I mean, hopefully, if that can be brought into the
we will. I'll make sure
paper on waiting list, because I think it's a very good point.
No, it's
Councillor Ross, if you'd like to go next.
Thank you, Chair. I've got four points. First of all, I'd like to come back to the point that Councillor Harrison raised with regard to staffing. I think it's very important that you've actually brought out in Pledge 13 the importance of staffing and the criticality of that to your operations. I think it might be helpful to all of us if you didn't simply focus on absence, but also things such as the inefficiencies, the cost of inefficiency, if you can capture this, that arise from absences. And I appreciate that's a difficult thing to capture, the cost of agency, staff, all of these things. But generally, I think it's a worthy thing that you've tried to bring out. But one statistic is insufficient to properly make the case to support the actions that you're taking to improve that situation. The second point I'd like to make is I'd like us to take us back to page 9 of the minutes and the underutilisation of the 7 rural hospitals that were identified there. And to highlight the importance of these to our rural areas. Many of us come from rural areas. These are also important to delivering the productivity assumptions that underpin the University Hospital Leicester reconfiguration in terms of community beds and step-down provision. And I think it's important that we don't lose sight of that fact. And I also think that we should be cognizant of the failure to deliver the promised community services arising from the closure of the Ashby Hospital. And therefore, we should keep, these are small hospitals, and we have a very small hospital in Rutland, and I appreciate that in the context of the greatest picture, but they are important to the communities that they serve. The third point that I'd like to make is there is no mention in here, and it is important for many of the communities that exist that are on the periphery of our area, is the issue of cross-border provision. I'm particularly thinking of Peterborough and Stamford, but there will clearly be other areas and places such as Hinckley. I think that needs to be brought out exactly what it is you're doing to deal with cross-border issues to support future health provision, because presently it is not clear in anything that I've read. And I'll also say that I've also read all the other health plans of all the surrounding areas, and none of them make mention of any. So this is not a specific criticism of Leicestershire, but this is an important observation that I'm making. I support the view that finance should be dealt with as a separate issue from this meeting and this subject. I think that's the only way it will be properly dealt with. Thank you, Chair.
Thank you, Councillor Ross.
Sorry, there's just a couple of things I'd say in relation to that. We do have a people's plan which sets out a number of indicators, and you're quite right. Other things like agency staff we monitor on a regular basis, we're required to actually, our bank usage, turnover rates and things like that. So we do monitor a range of staffing indicators. Totally and utterly agree with you in relation to the hospitals. The community hospitals, we need to make sure they become hubs of communities and that we deliver whatever we can. And hopefully this plan indicates that we have a desire to deliver as much as we can locally that is safe to do that. I have no background in relation to the Ashby thing, so that may be something that we could just take offline. The cross-border provision, we are doing a number of things, but it differs in one place to another because the issues are different in relation. One of the major things we're looking at is how do we get interoperability between systems. So that's a key piece of work we're working on at the moment. And for example, in the Peterborough and Rutland teams meet on a regular basis. So the staff in the ICB that look after Rutland will meet with Peterborough on a regular basis, try and get that communication and sharing of information. But the biggest thing is that interoperability, which we are working on at this moment in time. Thank you.
Thank you very much. Just to note also, actually, in addition to the reconfiguration plan coming back to the December meeting, we also have a workforce report coming as well. So that will actually include a huge number of the items that are covered, so which is good. And obviously now we've got the medium-term financial plan as well, which we discussed. So I think we're actually in a good place for December already. Mr. Howson, do you want to get a quick point and then we'll move on? Thank you.
Thank you, Chair. I don't.
Oh, sorry. Yes, I didn't see your hand. Sorry.
Oh, you have to wave a little bit. I don't know whether Councillor Ross was referring to the Ashby de la Zouche Cottage Hospital or whether there's another Ashby. But it is if it is Ashby de la Zouche, it was sold off and closed. It's now some sort of little business centre. And when I inquired deeply into the funds, apparently, eventually, I was told they went to buy iPads. So people had iPads, but a community lost and a massive intervention. And this is something you've really got to look at, because you talk about travelling, but if you're travelling minimal distances, you can probably walk or you know, it's not the stress for everybody. What you're doing is creating these great monsters instead of where people live. They want to be treated and looked after wherever possible. There we go. Thank you, Mr. Chairman.
So our strategy is to try and deliver as much as possible locally. There are some things that you can't because you need the medical support of a bigger hospital, but wherever possible, we are trying to deliver things locally.
Thank you very much. Councillor, you have a final word in that case.
Thank you. I sent an email, gave feedback on this back in May, but I didn't have a response. So I'm going to sort of ask the same question again. My concern lies around CAMS, Children and Adolescent Mental Health Services. And I see you've got a strand for children. I see you've got a strand for mental health. Brilliant. But what I don't see in there that to me, I think is vitally important off the back of everything that we hear in the news and COVID and isolation and everything is about some explicit targets, information, reference to children and adolescents. And I would have liked to have seen it on the one where you put them all together, the 4, 5 and 6, where you've got sort of explicit pledges there. I would have liked to have seen something around children and adolescents. My concern very much is that because it's not referenced, we can lose it. And we absolutely can't afford to lose it. This is our future generation. So to me, I have a really big worry about this, that it's not explicitly referenced and it's not in that other pledge. And that's basically what I said back in May.
Okay. I'm sorry about the fact that we didn't pick that feedback up. I think it's a valid point and we'll take it away and have a look at it. But I just want to reassure you that children and young people is really high up on the RCB's agenda. It really, and in fact, I spent most of this morning talking about children's and young people's agenda. So it is really high up on both our agenda and LPT's agenda. But we'll take that away and see how we can weave it in.
That would be brilliant. Thank you.
I think likewise, I'd like to introduce you first as part of the questioning on item 9, if that's okay, because I think it's relevant to item 9 as well on the agenda. Yep. Okay. Thank you. Okay. Look, thank you very much, Sarah. Amit, that's really good. We've got some good material to come back in December, and look forward to seeing all of that. But thank you very much for bringing the 5-year plan to us. That's very kind. Thank you. Thank you. Okay, now move on to item 8, which is the delivery plan for recovery access to primary care within the LRR system level access improvement plan. So we have to help us with that, Yasmin. Excellent. Good to see you. Thank you very much. So likewise, we'll try and take as much, obviously, of the paper that has been supplied as possible. I think you might have additional couple of slides as well. Is that right? Okay, and with the slides, do you want to deliver them, sort of hit us with the slides, and then we'll come back and question as and when?
I haven't got the slides. You can upload them.
Have you got? Are they emailable now? Or can you actually put them straight up?
Yes.
Okay. All right, we'll pause. We'll talk amongst ourselves for 2 seconds while you do that. There's nothing worse than putting somebody under pressure when they're trying to operate IT. At least that's my excuse permanently. Right.
Just sent it to you, Ewan.
County Hall email systems sometimes can take hours for emails to get through from other areas.
From across the deck.
Oh dear. I think I've still got about 3 emails that have never actually arrived.
Okay. Well, whilst Ewan
They're either instant or they take hours.
is receiving that, I'll just introduce myself.
Okay, please do.
I'm Yasmin Sidiot. I'm the Deputy Chief Operating Officer for the ICB, and I head up primary care transformation for the ICB as well, hence the reason why I am here presenting this today. And I think I've been a few times before to talk about primary care, so this is kind of a continuation of the conversations and the discussions we've had previously around primary care and primary care access, which is really the focus of the topic today, which is pretty much around primary care access. As you know, for the last few years, particularly with the pandemic, we had sort of responding to the pandemic. Last year was around recovering from the pandemic for general practice, and really this year has been really focused around how we start to improve access, and particularly around some of the key areas. And these are not just the local elements, these are also part of the national guidance that was issued as well. Particular areas of concern and challenges that remain is about how we tackle that rush in the morning at 8 o'clock. So there we go, just the next slide. Thank you. Tackling that 8 a.m. rush, I think pretty much most of us will have experienced this when we've tried to contact our GP practice first thing in the morning. You ring up at 8 o'clock and you try and get an appointment for that today. That is been part of what has historically developed for many, many years because of the way general practice was set up. And now what we're trying to do is really evolve general practice into a different way, and tackling that is really important, particularly from a patient experience perspective, and ensuring that then patients get that easier, quicker access and the help that they need from general practice as well. And continuity of care.
that comes up a lot when I speak to people out there, when we talk about experience. It's about that continuity, being able to go in to see your general practitioner, be it the general practitioner, the GP, or the nurse, them understanding what your conditions are. And I think particularly if you're people with long-term conditions, you've got lots of things going on, having that continuity care is really, really important. So that's kind of really the three key areas that we're focusing on as part of our sort of system level plan, and also looking at our place-based plans as well with our primary care networks. I'll flash this slide up, but I'm not proposing to go through it in lots of detail. It's just setting out the strategic sort of context. So we've got what is the system level access plan, and that is informed by our primary care network level access plan. So each primary care network, and we've got 25 primary care networks across LLR. We've got 10 in the city, we've got 1 in Rutland, and then the remainder in the county. So you can imagine in terms of the number of networks, they serve populations up to about 50,000 people across LLR. And those plans are very localised, as you can imagine, they're for their patients and their population, and that informs our system level plans. So I won't go into too much detail. There's a lot in there to take in, but it's just there to sort of set that strategic context. If we go to the next slide, the real question, and I know there's lots of narrative in the report, but I felt what you would want to know and what you would like to understand is, what does this mean for LLR? What are we going to do in Leicester, Leicestershire and Rutland in terms of access and the areas of focus? Listed those out. Really, the primary care, secondary care interface is really important. And if we just think about the conversations we were having as part of the 5-year plan earlier, particularly around waiting lists, etc., there's a real interdependence between primary care, general practice and secondary care. What happens in secondary care impacts on general practice and vice versa. So ensuring that we can improve that interface, we can make things easier, sort of look at how we can take out areas of bureaucracy, etc., is really important if we're going to be able to improve that, but also make sure that those clinicians' time is spent in the right places. So this is also about how we enable and release the time of clinicians. Community pharmacy is really important. So we talk about primary care and talk about general practice. Community pharmacy is a very important part of primary care and that overall primary care piece. And increasingly, community pharmacy have got a much more significant role in delivering primary care type services and support that enables general practice to be able to see a breadth of patients that they've not been able to see before. And I think that's really important. Antimicrobial resistance, that continues to be a real case of focus. This is about reducing that resistance to ensuring that we're safely and appropriately using antibiotics within the system, so that we keep reducing that resistance to sort of antibiotics as well. Within the digital development arena, this is really very much about things like NHS app, looking at cloud-based telephony, all the types of digital technology that supports general practice in becoming more efficient around how they deliver their services. It doesn't necessarily always mean that every patient will be seen online. We know for our patients the needs are different. Some patients can do that and that's appropriate. For some patients, that's not appropriate. So how do we achieve that balance of access for those patients where actually they want to do more things digitally, and then you've got some patients who don't? I'll whiz through a couple of other areas. I won't sort of think in too much detail, but I also wanted to just pick up. So if I go to slide 7, which specifically focuses around workforce and looking at what we're doing, supporting specifically targeting with practices who have got specific challenges, who are facing specific issues, and how do we sort of put that intensive support into those practices and primary care networks. So we've got a huge programme of work, and we've got 32 practices that we have already identified as part of the work in 23-24 to look at a more proactive I'm getting a bit of feedback on that one. Okay, sorry about that. 32 practices for proactive support across 23-24, and it just identifies how we've prioritised those practices and what we're doing with regards to that. So that's 23-24, and what we're also building in is a rolling programme so that we can do this with every practice across LLR 24-25. So we've got 32 now, and then remainder going into 24-25. Just so for your information, I think I've said this before, we have over 130 practices in LLR, so you can appreciate the volume that we're going through in terms of this piece of work. And hence the reason why it's happening over a course of a number of years rather than trying to do it all in 1 year. Workforce, we talked about workforce. We've got some real challenges, particularly around our GP workforce, although saying that for each place that challenge is a little bit different. So we've got good growth around GP workforce in our county areas, but in city we've got continuous challenges around attracting workforce into our really city practices and then staying there as well. So there's a huge amount of work we're doing around things like using fellowships, etc., working with the universities, and really sort of being to put in some more intensive work around how we attract that workforce. We also recognise the value of other roles in general practice, and that has been a real evolving picture over the last 3 to 4 years, with more and more roles being introduced into general practice, particularly through the primary care networks. Some of the roles that I think have had a real impact are around things like clinical pharmacists, first contact physios. They have been really welcomed. We've got advanced nurse practitioners now. We have emergency care practitioners. These roles supplement the work that general practitioners do, and what we've found when we've been out there and engaged with patients, they see the value of these roles in some of those areas where if they didn't have them, getting an appointment or seeing somebody around those specific areas of issues would have been really challenging. So that continues, and we continue with that plan over the course of this year as well, with a further, I think, 25,000 additional roles being recruited to across general practice. Comms and engagement is a real challenge, and the continuous bit is around how do we support our practices to effectively engage and communicate with their patients. On a one-to-one level, that works really well, but I think around some of the wider areas around how they communicate around the access issues, around roles, etc. So we're putting some very specific work in this year to really support our practices around engaging positively with their PPGs, really using the PPG network, the patient participation group network, to support them around how they work within communities and work with their patient population in a way that means that that engagement is improved, because the only way sometimes often explaining things or enabling people to understand how to use services better is by talking about them and talking and understanding what causes people challenges. We're also at the moment working on our winter plan for 23-24 for primary care. That is at the moment in development, and I'll be more than happy to bring that at a later time. It's just not quite there yet, and it's still got to go through our governing bodies as well. But I've put some basic things into the slide pack just to give you an idea of some of the areas that we're looking at from a winter perspective, particularly with a focus on acute respiratory infections. And I'll stop there and open for questions.
Brilliant. Thank you very much, Jasmine. You only just remind me, I think the winter care plans are actually going to the individual HOSC, so they are going to all get covered, hopefully, by that. Right, we've got a queue. Mr. Howson, you're not first this time. Mr. Whittle is. Jeff, over to you.
I think it's working this time. Just a couple of very straightforward questions. First of all, everybody accepts there are, I think it's been described as unacceptable variations between different GP practices in terms of the quality of the service they offer. Just can you advise whether we have variations within a PCN, or are they mainly variations between PCNs, i.e. some are doing very well and some are doing less well? And my second question, I'm hearing from GPs that one of the main causes of frustration, well, one significant cause of frustration is people that are on a long waiting list for elective care keep going back to their GP surgery again and again saying, have you heard anything? I'm still waiting. Can you write and chase them up? So would it not be possible for whoever the patient's been referred to, whether they take ownership of that particular patient and their issue, and they're told this is a person to talk to, because it does seem fundamentally inefficient to keep going back to the GP as a middleman. So just a suggestion there.
No, thank you for that. Yes, in terms of that last question, that work is part of that primary care, secondary care interface. As you can imagine, there's lots of nuances around some of this, especially when you've got, do you send people back to the consultant? Is there other ways in which we can support patients? Because often patients that are waiting, they've still got a health problem. So it's making sure that they're getting the appropriate interventions for those health problems as well. So sometimes they still do need to see their GP, and it's understanding what they can be and should be absolutely going to see their GP about, but what is the bit that they need to have that interface with the secondary care provider, for example. So that's the nuance that we're working through the primary care, secondary care interface work, which we call transferring care safely. And you can imagine that the clues in the title of that piece of work is about making sure that what we don't then have is patients slipping through the net and actually their health worsens, or when not being seen by the right clinician at the right time for what they need to be seen by. So sometimes it looks like the face of it very simple, but when you start to unravel some of that, it is quite complex. So it's just about making sure we're safety netting those things as well, as we're trying to look at how we make processes more efficient. And then in terms of the first question, just remind me again, because
yeah, I'm just asking whether the variations are between PCNs or within PCNs. Thank you.
So we've done quite a lot of work over the last year and into this year, where we have looked to really try and look at how we reduce those variations within PCNs. So a huge amount of work has gone in there, and we have done some work. We know that there are still some of our PCNs where we've got some variation within those PCNs, and we're working with those PCNs to look at how they support one another in those networks to bring that sort of quality up and on par with the rest of the PCN. And what we're also doing is the work that we are trying to do, which is connecting up PCNs with other PCNs who have got best practice to share and ways of working that could improve their PCN as a whole as well. So as much as I'd like to be able to sit here and say we've completely reduced, taken out all the variation within each PCN, I couldn't say that wouldn't be right. But what we've done is we've made some real inroads into that and reduced some of that variation. But what we still got existing is those variations between PCNs as well.
Thank you very much. Okay, I've got Mr. Harrison followed by Mrs. Heaton. Have I got anyone else who wishes to speak on this item? Mr. Ross, Councillor Ross, and also Councillor Bonham. Okay, thank you very much. Right, okay, Mr. Harrison.
Yasmin, welcome this afternoon. It's been very informative listening to you. I've wondered if I've made a mistake. Did you say 25 or 25,000? I wrote 25,000, but it must be wrong, obviously.
25,000.
New staff, you were talking about some
24,000 new staff across the piece. Yes, so this is the national figure. Just looking at Mayor, it's a national figure. Yeah,
not Leicestershire.
No, sorry.
Right. Okay, I think that's where Mr. Harrison was coming from.
Really easy.
My ears likewise started going like that.
Not 24,000 across England.
Right, thank you. Because about a year or so ago, we had a project come forward for about 100 managers to help doctors do their job. It was described like that. And obviously, you probably know that programme and how it went on, because we thought, well, it's clinical skills we need, don't we really? And I just thought at the time, well, it wouldn't be long before they'd need an assistant. A manager doesn't survive on his own. He's got to have an assistant or a team. Can you amplify where that ended up, please, Jasmine? Thank you.
So if I'm correct, we're talking about what we implemented as the Royal College of General Practitioner programme with the Royal RCGP, which wasn't just managers, it was managers and clinicians, sort of a team that would go into a practice and work with the whole practice team. So the clinicians would do the sort of peer-to-peer review work with the clinical team, and the managers would go in and work with the management team of the practice. So that was a piece of work we did last year, which helped us look at that in PCN variation. So what we absolutely haven't done is sent managers in to tell clinicians how to do their work. I think I can very safely say clinicians do that and will do that piece of work. What we have done as part of that is opened it out to have managers that go into work and support managers in those practices. Because remember, each general practice is a business in its own right, and therefore, as well as the clinical support, it needs the business support as well to support them to sustain themselves as a business so that they can continue to deliver the services. So what we've done is put in a whole team, and actually we've seen some really good results out of that, particularly where those practices were struggling on a financial footing, for example, or just being able to. So we've seen an improvement in the number of appointments they've delivered, in around how they're processing patients through their system. Some practices who'd had their list closed, reopening their lists as a result of that as well. So we've seen some really good result, but obviously that was a very small programme that we started, and with the work that's now coming in through NHS England, that enables us to open that out to much more wider cohort of practices.
Much, Mrs. Seaton.
Thank you, Chair. You did mention the PPG, the involvement of the patient participation groups, which I am one of them. It's Silverdale Surgery in Thermiston. And as part of that, we are encouraged to attend, probably on a monthly rota, attend our attendance at the surgery waiting rooms, and to ask the individuals, have they got any problems, and this, that and the other. I've done it twice and I will not do it again, because each time it's the appointments. Whenever I speak to them, that they're not concerned about their health matters that they're waiting for, and then they are being seen, but it's how they made that appointment. And some of the stories you hear are quite shocking. You know, they're being on the phone for half an hour waiting for the queue to go down, and then when they do, no, ring back at 2. And I want to know what you are doing about that. What alternatives are there to do that?
So some of the alternatives is around getting our practices and really working with them to look at how they use the digital options for those patients that can use the digital options. So we know that we can see how many patients have now registered, for example, for the NHS app in LLR, and we can see how many logins happen as a result of that. And, you know, month on month, those logins are increasing. So we're working with the practices to say, you've got quite a significant amount of your patients that are on there. What appointments and things you can make available on there, so that you've got those patients then not having to phone in, freeing up your phone lines for other patients that haven't got that digital access, but the phone line becomes really significant for them to free up. What about the other thing is that we've practices that have had historically and traditionally every patient ringing up at 8 o'clock, and then they flick them into 2 o'clock. Actually, a lot of patients don't need to ring at 8 o'clock in the morning. They should be able to ring at any part of the day. I know they don't, and this is part of the work that we're doing. It's a juggernaut that we're having to turn around because of years of custom and practice in general practice, that we're now working with them and getting them to challenge in a way that enables them to see changing their model of delivery can have a better impact without them feeling overwhelmed. The thing that we get back, and I'm sure you've heard this when you've fed back to the practice, they say, well, if we do that or we change this, we'll just get lots more patients calling us in. And actually, often reality is very different. So it's about doing some of that, and also about actually how do you at a primary care network level look at scaling up some of the calling facilities in a way that enables you to use that workforce better. So Silverdale is a small practice with about 8,000 patients. So you can imagine small practice, 8,000 patients. You've got a huge amount of those patients ringing in every day. Very quickly, that becomes a very difficult situation to manage. They were working as part of their primary care network to scale up their ability to use their staff across the network to take those calls, and that could support them in a different way. So these are the pieces of work that we're doing, but we're doing this in a way that doesn't make the practices feel threatened that we're making them do things and really quickly, but B, also make sure that we are taking them with us on that journey as well as their patients, and also sharing the best practice from other practices that have done that and have seen some real improvements in their patient experience. And that's one of the things we are doing this year. We've got the baseline of the patient experience questionnaires. What we've said to every single practice and PCN is what our expectations on those improvements are going to be, in order that for us to be able to say, okay, based on that, we can release. So we've withheld from, for example, around the PCN access plans, about 30% of their funding. We'll release that once we can see a tangible improvement on those patient experience things. Those are ways in which we are working with local PCNs and practices to look at how we change that. Now, I'm not going to say that come next year that will completely eliminate, but what we want to see is some incremental improvements on that, and then we can build upon it.
Thank you. If I can come back, Chair. So as a PPG as a PPG member, then, is there anything I can do? Because at the moment, I just feel as though I'm ticking a box. I'm just there for ticking a box. Oh, we've got a counsellor on our PPG, and I'm not doing anything. I'm not improving the service at all, and it's a waste of my time and a waste of their time.
Absolutely. So I know that we have a PPG network meeting that's facilitated by the ICB. I'll pick that up with Joe Ryder, who leads that up, and look at what we can do to support the network around how to then take those, how to support and facilitate the improvement actions, etc. So I'll pick that up as an action to work through.
Thank you very much. I think the point on consistency of appointment, I think, is important. I mean, Councillor Whittle and I were talking earlier about sort of differences between our respective practices. I used to be able to book everything online. I haven't been able to get an online booking for a year and a half. You likewise have had actually quite a good experience on the basis that you automatically can book a callback call, not waiting till 2 o'clock, but actually the practice will call you straight away. So, consistency between practices, I think, would actually give a lot of people confidence that their practice is actually acting in the same way that others are as well. And that would be really, really helpful.
Sorry, Chair, if I could just come up there. And I think you'd reduce the no-shows, to be quite honest, because I think people are so desperate. Oh God, I've got a doctor's appointment, I must turn up. I'll grab it with both hands, whether I can make it or not. And then when push comes to shove, they can't make it and just don't show. The no-shows are terrible. There's probably an hour is wasted within each GP's day of people that have not shown up. So.
Thank you very much. Okay, we've got two final questions. We've got Councillor Ross followed by Bonham. So, Councillor Ross.
First of all, can I say I found your presentation very understandable for the layman and succinct. Thank you for that. My question relates to how this is going to be communicated to the population generally, because you're more aware, I'm sure, than I am, that many people believed that they wanted to have a doctor's appointment, but were being offered a nurse's appointment. And now we're talking about extending this to using pharmacies. I think that's a good thing, personally. So my question really is, conscious of the age profile of people. How is this going to be communicated? What is the communication plan, and what is the timescale that will take place over? Thank you.
Thank you for that, Councillor. It's a really good question. It's something we've been working on and I'm very passionate about because I very much strongly believe that talking in simple language and being really simple about these things are really important, because everybody's understanding of these things are different. And like you say, historically and traditionally, if you're so used to seeing your GP and then all of a sudden your practice is saying, oh, well, now you're going to see a nurse, and you, as a patient, you're thinking, well, how on earth are they going to know what's going on? This is the reason why there's been a huge amount of work we've been doing, and particularly working with voluntary sector partners as well. So the traditional ways in which, you know, putting information out there on websites, etc., is all good and great for those people that can read it and can access it. But for a lot of our communities, it's the word of mouth that works the best. So how do we do that? How do we utilise our voluntary sector organisations and our community groups, our community leaders out there in order to be able to do that? And what we're also doing is bite-sizing that. So I can go out there and say we have 15 new roles in general practice, and that's quite overwhelming if I went out in one go with all 15 new roles. So what we're doing is sort of on a month by month basis, talking about specific roles, what that is, and then supporting practices with the information in a way that they are able to deliver that to their population and their patients as well. So that's the plan, and that's what we're working on. And obviously that has taken some time to pull together, because again, we've taken feedback from PPG networks when they've come to other meetings, representatives, they've said this doesn't work. You know, the practice struggles with communicating this because of the way it runs itself. Is there a different way of doing it? We think this is a different way of doing it. So how do we do that? And I think there's also a big role for our PPG networks. You'd much rather go and sit in a waiting room and talk about different roles than just asking the same question and getting the same response back. So how do we empower and facilitate that as well? And that's also something we're working on with our engagement team, who have these regular forums with different groups and different organisations to support us with that. We've seen some success with that. Like I say, people are much more aware of what a clinical pharmacist now does in their practice, what a social prescriber does, and the benefits of that. So we're starting to see that drip through, but that's over time. And like I said, if you think about in the last 5 years how much general practice has changed compared to what it used to look like for at least 20, 30, 40 years before that, it's a massive change, and it's a big change to take people through in a very short space of time.
Thank you. I was particularly concerned, I suppose, about the older members of our communities, but thank you for that.
Thank you. Final question from Councillor Bourne.
It's picking up on some points made earlier, which were partially answered about the consistency in being able to get appointments. Is one of the reasons why my surgery, and I'm sure others, are no longer offering digital appointments, simply because they want the receptionist to be able to triage appointments first of all and cut down the number of appointments, because that has been a change in the service, and it is now a situation where yes, you do have to wait 20 minutes, half hour sometimes at 8 AM to get through and to get an appointment made, and then it's frequently they refer an appointment where the doctor phones you back at an indeterminate time. Now for me now that's okay, because I've partially retired. When I was a full-time teacher, I could not have sat on the phone for half an hour at 8 AM, nor could I be available throughout the day to be phoned back. And the previous digital appointment system used to work much better for me. So how can we get the consistency, and how can we get the accessibility to appointments for everybody?
Absolutely. So I think for a lot of practices, it's managing the demand versus how they open up the appointments, which is the balance that they're trying to strike all the time. There are different ways in which they can do that, and practices can do that, and this is the bit that we're working with them to say there are things like the online consultation processes that they can utilize to help them. The cloud-based telephony technology enables them to set up callbacks. That means that they can do those within certain timeframes. So it's getting them used to that different technology and how they use that to their advantage, that enables them to still do the triage and management and get the balance on that, but means that for a patient, they're not waiting inordinate long amounts of time or not knowing when that callback's going to happen or when they're going to get that appointment. So those are the things we're working through. And we've got, I think, Maya, correct me if I'm wrong, most of our practices now on cloud-based telephony. We've still got some practices that are not on, but our aim is and our pledge is that we'll get everybody in for 24-25. The next bit, which has been working on, is those that have got it, how are they maximising the use of it and taking advantage of the full range of services that they can put in place as a result of that technology, which I know that not all practices are using to its full benefit, because if they were, there'd be so many things they can do differently. And I think that's why, Councillor Whittle, you've found it your practice they can offer that callback service. It's sometimes just a switch of a button and different ways of working, but it changes and revolutionise the experience that patients feel, and B, also for the practice as well and the clinicians.
I'd like to thank you, Yasmin, for answering our questions so clearly and succinctly. And can I just request that the delivery plan tracker that was attached to this report could be in English and a little bit understandable. So most of it, I just couldn't understand what it was trying to say, just as a comment.
Yeah, absolutely. We'll work on that and get a much better readable format.
That's great. And then it helps us as a committee to also track how progress is being made, which is essential. That's our purpose. So, Yasmin, look, thank you very much. There's some really, really good questions, which hopefully you gave pretty good answers to, but also likewise, hopefully can help you develop the service and talk to practitioners. So thank you very much for spending time with us this afternoon, and we look forward to seeing you again soon. Okay, thank you. Okay, we now move on to item 9, which is the Leicestershire Partnership NHS Trust paper, which is creating high quality compassionate care and wellbeing for you. So at the moment, I only have Jean Knight down, but there seems to be multiple Jean Knights, so I'm assuming that Jean has brought a team with her. So would all of you like to introduce yourselves, and then if you want to spend a little bit of time, just we've obviously absolutely read your paper. There were additional slide deck, which I know has been distributed to all members, so everyone's had a chance to actually look at that as well. So if you use a couple of minutes to drawing attention to areas of interest, and then we can open up to questions and discussion points, that'd be great. So over to you, Jean.
Brilliant, thank you. So I'm Jean Knight, I'm the Deputy Chief Exec and Managing Director at Leicestershire Partnership Trust. I'm just going to introduce my colleagues. So David.
Thank you. Good afternoon. David Williams. I'm Director of Strategy and Partnerships at LPT.
Hi, everybody. I'm Tanya Hibbert and I'm the Director for Mental Health at Leicestershire Partnership Trust. Afternoon, everyone. I'm Dr. Anne Scott. I'm the Chief Nurse at Leicestershire Partnership Trust.
So you're quite right. I did bring some colleagues with me, mainly because I wanted to make sure that we were able to answer any questions that you had here today. Such an important topic. We want to make sure that we had the right people in the room. So really, we wanted to share with committee today LPT's progress in terms of delivering our vision, which is on the slide, hopefully. No, you haven't got the slide up, but it's on the first slide, which is creating high quality, compassionate care and wellbeing for all. Do you think we'll be able to get the slides up? Thank you. Okay, I'll carry on talking then. I'm good at that. Okay. And I think really what we wanted to do, as we agreed before, is focus on the two elements, one around the public consultation outcome around mental health, which we've touched on, I've heard already today, but also then in terms of our engagement and our progress with some of the elements that CQC have raised before, and we've obviously had quite a lot of conversations and work with them since I think we last came to present, or I think Anne was here actually. I think the rest of us are quite new. So if we can go on to the second slide, please. So this is just to give remind everybody really in terms of the consultation that happened in 2021, and it provided some really helpful material which informed then the priorities of the Step Up to Great mental health programme. So the programme is very much a collaborative, and it's a collaborative which was formed in 2022. Tanya is the SRO for that collaborative, so I think it's really important that she's here to hear and answer some of the questions that you may have. Really, that very much coordinates decisions, the strategy, and the plans, solutions for delivery of better mental health services across LLR. And you can see here that these priorities very much define what came out of the consultation that took place. And then next slide, please. So one of the key deliverables that our population said to us was really important, I've heard here in previous agenda items, was actually to be able to deliver at neighbourhood level. And it's something that we've absolutely focused on. So we've now have all the neighbourhood leads appointed across LLR, which is incredibly important. They in themselves are then developing the mental health networks at neighbourhood level, which then deliver and feed into the ones at place level, which gives us that ability to really understand at local level what people want and what people need based on the population around mental health services. We've had extensive amounts of data from neighbourhood level, which has fed up and into the services that Tanya oversees in terms of how we are running those. And I think it's really important that we are creating that triangle effect in terms of what the overarching plan says, all the way down to what people actually want at their neighbourhood level. So that's moving on really well. And we've also then developed some of that ability to lead into the secondary care services that LPT provide to make sure we're joining up at every point in terms of that delivery. And one of the important things around that, if we can move on to the next slide, is just to show you the size in terms of what Tanya and her colleagues have achieved, which is that ability to have 25 cafes up and running. That's a significant step ahead, I believe, in terms of what we're actually providing. And those cafes provide that crisis support for individuals. They're drop-in centres. You don't have to create an appointment, and they are done in partnership with different voluntary sectors across the county. I think, again, that's really important, that we're not just reliant on increasing the NHS workforce, but we're using the skills and abilities of other people across the county. So I think that's incredibly important. And actually, we've had some amazing feedback from people that are using that services, that it's a lifeline for people who need to have that support from a trained individual very quickly. So that's a little bit about mental health. If we can move on to the next slide, I'm just going to talk about, oh, here we are, well done. Amazing, far more organised than I am. So just to give you a bit of a background then, so in 2021, the CQC undertook another visit within LPT. They did focus just on the mental health inpatient and the psychiatric intensive care unit sections. They were really positive in terms of what they found. They noted that we addressed all of the concerns that they'd previously raised, either immediately, or we had a programme of work that were going to address that, including the eradication of dormitory accommodation. Since then, we've also had some conversations with them as a system, actually, which I thought was really important. So people might be aware that the CQC are going to be doing more reviews based on a system level rather than for individual providers. And one of those elements was looking at the urgent and emergency care pathway across the system, which was really, really helpful. And I think I was actually out at the infirmary the other day talking to the psychiatric intensive liaison team, and they were so proud of what they achieved as part of that inspection and the feedback that the inspectors gave to them. They were saying they're very much focused on holistic care, on a joined up care plan, and that the CQC can see the work that was being undertaken across the two providers just to provide the best care they possibly could for the patient, which is really what we're all here for at the end of the day anyway. So I think that's really positive. And I'm sure some of you will be aware of the Rutland joint CQC and Ofsted inspection earlier on this year, which again is a great testament to partnership working, to people working collectively for the best outcomes they can possibly provide for families. And that again provided some really fantastic feedback in terms of what's happening. In addition to that, just so people are aware, Anne and her team, along with Angela and myself, meet up with CQC on a regular basis just to discuss things that are happening and making sure that we're keeping them abreast of the improvements that are being made across LPT and will continue to be made across LPT. So if we can move on to the next slide, this really just gives this slide and the next slide a bit of an overview in terms of what's been achieved and what we're doing. So you can see there that we've done quite a lot of work in terms of the Anne, I say we, it's a royal we, quite a lot of work in terms of what we're doing around the accreditation of quality and ensuring that we're sharing learning across the whole of LPT. And that took a significant amount of work from Anne and her team, and in fact all of the operational and clinical teams within LPT. What that does mean is that we have that assurance now that learning is really truly being embedded and being shared across the whole of the organisation, which is absolutely essential. We've got a really comprehensive plan called Our Future, Our Way, which is looking and listening to what our staff are saying to us and what they want to see change. There are experts. They're the people that work with our patients and the colleagues every day. And I think that what that enables us to do is really focus on the things that will make a difference. So more positive and happy workforce you can have, the more productive and great care they do provide for our patients. So we are very much focused on that. We've talked about the eradication of dormitory accommodation, which Tanya and her team are very much involved with, as a lot of it was in the mental health arena. So we've just actually, I think we're starting the work on Langley very shortly, or I think that's the last ward to go. So that would be fantastic. And in the last slide, so people may or may not be aware, but we have regular CQC visits around the Mental Health Act inspections. We've actually got one going on today, and they've also actually been really positive. We've had some fantastic feedback in terms of what we have improved, what we've changed, and what we will continue to improve and change going forward. Again, in terms of the well-led piece, which is a CQC governance section, we've had some good feedback on that. There's more work to do. There will always be more work to do, but we're absolutely dedicated to do that. And then finally, I think what's really important, as I've mentioned all the way along, the system working, and having been, I am relatively new to Leicestershire, I'm incredibly impressed with the system working that we have here across councils and across health and care services and the voluntary sector. I think it's fantastic. And we will, of course, continue to be part of that and drive that forward. So that's really a quick synopsis. Really happy to take any questions, Chair. Thank you.
Thank you very much, and that's good to hear. I mean, obviously, you touched on where mental health support had come from within the county, which, to be frank, there were severe problems which have been highlighted, particularly on some of the residential care areas. So it's good to see, obviously, that there has been significant progress, and it's I think I can't remember who actually raised it earlier on within the 5-year plan. There was reference to the fact that obviously now Leicestershire is sort of very much in the sort of top end of national performers on mental health support, which is great to see. We did have a question earlier on, and I don't know whether you actually want to raise again, which actually links to CAMS, which I think, it's not expressly referenced in this paper, but obviously, the support, particularly for children with who require mental health support, unless it's provided efficiently and correctly and promptly, can lead to significant long-term pressures and problems later on in life. So I don't know if you want to actually re-ask the question.
I don't know if you were here earlier, but it's mainly about access to CAMS services and the incredible long wait and how high the threshold is often for people to even get a referral, and then they seem to get triaged and waiting 2 years, and the detrimental effect that has on huge swathes of the population, and even the parents and the schools and everything. So I see on here that you've got reduced long waits for services. I think I'd be really interested to know what work you're doing around CAMS, what we can expect in the future and how that's going to look, especially because it wasn't really referenced in the 5-year plan.
Yeah, absolutely. I think I can safely say that myself and all my colleagues are worried about CAMS in terms of the waiting lists and what the impact that is having on our population. I think it is important that we do recognise the amount of changes and transformation that's happening within the service at the moment. So, for example, the mental health in schools. We're now on wave 9, and we're seeing some really positive outcomes from that. And I think it was a really brave move from the government in terms of implementing that, because it's very much a preventative piece. And I've actually been out with some of our practitioners in schools and really seen the impact it's having on our very young people in terms of preventing them and giving them the tools and support they need so they can cope with their mental health and their changes in emotions that they would experience as they go through. We've also got the intensive outreach service, which is a relatively, again, new service. What that does is treat and manage young people with significant mental health issues to prevent them from having to come to an inpatient unit, because we do know that actually it's much better for people to be treated in their own communities rather than being admitted to a ward, particularly at a young age, between 14 and 17, when you are very vulnerable. We do also know within Leicestershire that we have historically counted weights for neurodevelopmental pathways along with our mental health pathways for children. And what that means is that we have been unable to really clearly see the weights that are just for children and mental health services rather than those with neurodevelopmental issues as well. And people will be aware it's all across the news. The weights across the entire country for neurodevelopmental assessment and treatment for both children and adults is significant. So this then enables us to really see clearly where we are. There is a lot more work that we need to do. The pathways are being redefined and redeveloped. There is significant triage just simply because the demand has increased so extensively. I think it's 125%, but I need to check that in the last 3 years. And I think that's another indication of where we are from a COVID point of view. But 100%, we all agree that there is absolutely more work that we need to do as a system in terms of the long waits for CAMS. Don't know if you wanted to add anything else, David.
I hear exactly what you're saying, but I think it would be remiss of us to not really focus in on that over a period of time, and I would really like to see data and analysis around that particular issue, because it's huge and it really worries me, and I'm sure it worries everyone here. So I think if there's an opportunity whereby we could come back and bring this back as a specific issue, I think that would be really welcome. And I'd also be really keen that we keep revisiting it, because it is such a worry for all of us. And I think if there's anything we could do, I think that would be great. But thank you.
Thank you. I'll be really happy to if Chair's in agreement.
I think that would be good to actually bring to the New Year meeting. We've got one. We've got quite a full one in December, but actually, I mean, it would be good to actually bring one back, I think, at the following meeting. Yep. Okay. Thank you. Okay, we have a question from Councillor Bonham.
I very much welcome the development of the mental health crisis cafes. And I think that's a network of people who just drop in any time would be very, very useful to many people. A few questions about them. I certainly know some of the organisations you're working with in Leicester who have been asked to run them. What is the consistency of training for people running them across the three authorities? Secondly, because it's being you're working with voluntary organisations, does that mean there are areas which haven't got the level of coverage you'd like, and what are you doing to address that? And thirdly, we were all aware, I think, that a lot of the issues that cause people stress and anxiety and mental health problems are related to other issues. I mean, certainly, I know from ward surgeries that it's issues like overcrowding in housing. It is cost of living and people being unable to meet the bills now. And I understand the crisis cafes have got some expertise in guiding people to support in those sorts of issues. Can you develop that further, please, and tell us a bit more about that?
Yes, thank you for your question. We do have a partnership arrangement, as you've already referenced, with a number of different charities, voluntary sector organisations. So it isn't a completely uniform approach in all of our mental health neighbourhood cafes. So it does slightly vary. But what we are trying to do is take a very needs-based view in each of our neighbourhoods with some more specific interventions that might be more useful to some populations more than others. So in that regard, the training is there's not necessarily a very specific intervention. It is about those voluntary sector organisations linking in more there isn't as much of a bespoke health offer going in. It's more about those local communities providing those resources to help support those people that do drop in, but they know how to escalate into primary care and secondary care services as is needed, to be able to give that more formalised mental health offer, if you like. So it's not specifically a health service as such, but we link in, we do drop-ins, we do visits into those neighbourhood cafes, and there is those interface and those links. We have a number of meetings with our voluntary sector partners as well to continue to develop what their needs are. They have mentioned recently about training, so that is something that we're looking at, just about even basic, mental health first aid training to help support for them to be able to be as effective as they can to help the sorts of people that are utilising the cafes too. And just with regards to the cost of living, you're right. It is again how we're trying to come together collaboratively to all pool our resources, and where we all have different access to different resources to be able to help reach those who are coming to the cafes with a whole variety of, as you say, wider issues. And that's where we try and there's things like the Joy app, which I'm not sure how much some of you might be aware of, but it was certainly an app that started in Rutland, and we've adopted to be able to roll out across the whole of LLR. It's quite an impressive app. And it's how we're able to link in together with all the much broader offer of resources that include things like, as you say, housing issues, food banks, all those different offers that are out there more widely. And because it's quite a vast network and it does vary so much from neighbourhood to neighbourhood, this Joy app is a really fantastic development that we've purchased in conjunction with local authority and the voluntary sector partners, so that we can all be aware of what the resources are in that wider offering that's available and know how to access them, tap into them, signpost people to them, things like that. So that is a really fantastic development happening live as we speak at the moment. Thank you.
Thank you very much for that. That's really, really helpful. So I quite agree that mental health cafes, I think, have been a sort of revelation over the last couple of years, and the signposting in particular comes up constantly, I know, in meetings here, and I suspect probably in the city in Rutland, because the ability to actually come face to face with people who have particular needs, strong needs, quite often who just need a bit of support, but also need hopefully people to be able to recognise where additional help can be provided, I think is incredibly helpful, and certainly coming out of the pandemic, they have been an absolute lifeline for a lot of our communities. So great to have the network to support you, but also supporting our organisations as well. So fantastic connection. Look, I can't see any other hands up, so thank you very much. So Anne, Tanya, David, and of course Jean, thank you very much for bringing this paper to us. Thank you very much for the work that you've been doing. Good luck with the inspection today. No doubt you'll get a phone call at some point to say it's been a huge success. So good luck with that. And we look forward to getting a paper back, hopefully in the new year, to cover in further detail some of the areas that we've been discussing today. So thank you very much for your time. Thank you. So we're moving on now to item 10, which is our final item for this meeting. This is an item from EMAS, which is about additional investment for Category 2 response performance improvement and workforce plan. So thank you very much. So joined today we have Susanna, who's the Divisional Director at EMAS. So welcome to you. You've got a nameplate, but for some reason it's all fallen off. So never mind. We know who you are. So that's good. Unless you wish to be incognito, in which case it's worked. So thank you very much for joining us, and thank you very much for the very succinct paper that you have submitted. We're obviously taking it as read, so that's great. But if there are any points that you wish to draw attention to for the next couple of minutes before we actually launch into questions or discussions, that'd be great. Over to you.
Fabulous. Thank you for letting me come, really. The main bit we wanted to share is actually, obviously, we've been given as ambulance service a significant amount of money, and it's for a significant and a very specific project in terms of reducing the number of time patients who are a category 2 patient are waiting. The time a patient should be waiting is 18 minutes for a response for us for a category 2. And this is a national initiative, and it's to get us this year, as in the end of March 2024, down to 30 minutes, and then the following year down to 18 minutes. So it's a kind of 2-year cycle more than anything else. There's just a few caveats that hopefully have come out in the report, but just to kind of make sure that they're kind of brought to life. The monies that have come to EMAS, so approximately 24 million for this year, that's EMAS as a whole. So that's across 5 divisions. So Leicestershire, Leicester and Rutland being one of those divisions. And of those 5 divisions, there are 6 ICBs, because Humber comes across to Lincolnshire as well. So the money is, and the target is across all of the divisions, but there is areas where we can see that where we can break it down into Leicester, Leicestershire and Rutland. So that's, I guess, one of the main things to do. It links in with Pledge 5 that was shared first of all with and the first presentation you had. And the other thing as well, just from an ICB perspective, again, just for awareness more than anything else, EMAS is not commissioned by Leicester, Leicestershire and Rutland ICB. We're actually commissioned as a whole by Joined Up Care Derbyshire, and then Joined Up Care Derbyshire do it on behalf of all of the ICBs. So just a few kind of logistics to explain more than anything else. So hopefully, as I said, the paper makes sense more than anything else. The 3 core bits we're looking at, so looking at how can we increase capacity, how can we manage demand, and how can we support staff through this quite significant period of change. And then there's just some of the ways that we're doing that delivery. And it might be that you kind of want to understand what that actually means in practice more than anything else. The PAS hours, so the private ambulance service hours, again, it's probably worth me pulling out now because it's the equivalent to some extent in terms of agency staff, if you're talking about nursing and doctors to some extent. So we have private ambulance crews that we always have every day to support our delivery. And part of the funding we are spending on an increase in private ambulance service, particularly in the first year of this plan, the reason being recruitment takes a significant period of time and we've got to deliver. So although that will be reducing in the second year, there is a bigger part of it in this year, but that's just so we can get going and get moving and get boots on the ground, so to speak. And our private ambulance service providers that are working really well with us and really delivering on what we've asked them to deliver, and a significant number of that comes into Leicestershire. Handover delays, and that's the main reason, that's a factor of getting handover delays down. If an ambulance is sitting outside a hospital, it can't be at a patient's house. And actually you'll note hopefully that there's significant improvements have been made across Leicestershire, particularly in the last, well, since the beginning of this year, significant improvement. Efficiency on scene time. These are just the little projects that go and just the little bits, the small improvement gains. And NHS Pathways migration is massive for us. It's a huge, so when somebody phones 999, it's the service that gets them to the right place, and that whole service is changing. And we go live with that in November. We're already in the planning and already in the working through all of that and started. Some of our calls are already being taken by, some of them are being taken by West Midlands Ambulance Service at the moment to ensure, and they're on that pathway already, and that's while our staff are being trained in the process of that. And that's probably the overview of kind of the key bits, but I'm sure that you've got questions that you want to pull out in this.
Thank you very much, Susanna. So look, I mean, to start off with, great to actually see the numbers coming down. Obviously, you talk about 45% reduction to actually sort of target in an LRR area, pretty well close to 30 minutes already on category 2, and I'm sure the target of bringing down to 18 minutes, I suspect you almost daily have a plot towards how to actually achieve that. My question really, and you touch on it in the paper, which is about handover delays, and obviously this is something that's been quite a significant talking point over the last 18 months or more, and I'm assuming your improvement, as you've outlined, is sort of hand in glove with the handover procedures and the way that the NHS, being able to actually have one of your ambulances pulling up and knowing full well that the patients can be taken out into A&E and through the hospital, so to enable you to actually get your crews back on the roads and responding. Is there anything that you can see at the moment that will actually stop that improving? I mean, you're obviously looking at this, and it's been a critical sort of change to enable you to actually get the crews back on the roads. But is there anything that you can actually see that's actually going to cause a problem for that, particularly over the winter months?
As you say, it's obviously a concern. I think at the minute what we're seeing is the capacity is there, and I will say the system have been brilliant in terms of all the system partners. Actually, where can we actually do all these people need to be taken into hospital? Can we work better in the community and divert them to begin with? The hospital and it's the flow through the hospital is the bit that will stop it if we can't get the patients out the other end. And that's really one of the key drivers of the system, is to get the patient flow through. If the patient flows through the hospital, we can get them in. And if patients are going to the right place and we've got the right services for a lot of patients in the community so that they don't need to go to hospital in the first place, then that in itself, pathways will help with that because it will help us direct patients better. But yeah, generally flow through the hospital is the key thing that will stop us making progress.
Well, it sounds like everyone's stacked in the sort of straight line as far as actually understanding that that's absolutely critical for the service, but also for the hospitals. Therefore, at the moment, you can't see anything that's actually going to cause a problem with making that carry on.
No, I think it's numbers, and it is whether, I think discharges is the key. If we can get patients discharged from hospital and into the right place in the community, that is absolutely going to be the key thing.
Okay, thank you very much. Right, can I open for questions? I know Councillor Whistle, you had a question from earlier on.
Thank you, Chair, and thank you for that presentation. I'd like to just talk a little bit about the interface with the private ambulance crews. Your report says you've increased the number by 18. Can you tell us what the total number is now? Because that's the increase, isn't it? Do you have a target for reducing that? I'm perfectly happy that this is a pragmatic response to solve a really urgent problem, but I'm just wondering about long-term sustainability. Clearly, we do have a capacity problem, and we do need to recruit more people. So one of my questions is, how do the terms and conditions of the ambulance drivers that are employed by the NHS compared to the terms and conditions of the private ambulance crews? A large sum of money has been made available. Could some of that go towards I don't know whether you use a term like golden handshake, but incentives to help you with your recruitment? And I just wonder whether the private ambulance crews who I just wonder whether there are issues around the interface, that they're used to working with different systems compared to the hospitals here in Leicester, particularly the general, sorry, the two acute hospitals, whether there are any issues around there and how you've resolved them. Thank you.
So we work really closely with the private ambulance providers, and we have, when we contract them, we have small numbers. So we only have a small number of providers, and they work in set localities generally. What you also find is the people that work for them generally work in the same locality most of the time, so they get very familiar with our processes. We've rolled out, we also have relationship people. So we have people that literally speak to the crews all of the time in terms of incident reporting and patient safety issues. Those are shared across all the time. There's that constant engagement in terms of how, if there's a concern with either a crew or the way they're performing, then that's shared both ways for learning on both sides. One of the other bits you talked about, incentives, and some people choose to work for private ambulance providers for various reasons. Some of them is because actually the terms and conditions, they can sometimes say, I want to work these shifts and I don't want to work those. And so it is usually personal choice. And we're always happy to work with anyone that want to come across, but usually it's a personal choice of the paramedic themselves or the technician that wants to work for those providers more than anything else. There is the plan, as I said, to reduce them, and it's very much a hit, and that 18 is across the whole of EMAS footprint, not just within Leicester, Leicestershire and Rutland. And what we do is we move the crews around depending on where the need is, and that's flexed across. That's one of the bonuses of being a regional provider, is we can flex that. So if one day there's more demand in one place, we can move crews around. Does that answer?
Also, increasing NHS capacity, presumably that means acquiring more ambulances. Are they easily acquired? And would that be a blockage to achieving the growth that we're looking for?
There's the potential that it could be, but there are places that you can lease them, and there are different ways around. And again, some of the vehicles, again, we have a mixture of vehicles, some that we use which don't have blue lights on, some that do have blue lights on, some that are cars. And so we work around that. And the private providers come with their own ambulances as well. So the crew, you get a crew and a vehicle as well.
Absolutely fascinating. Councillor Ross.
Could I just follow up on Councillor Whittle's question, because this is about the long-term operating cost of services, and the question applies generally. We're not just picking on the ambulance service, but is there going to be a policy come post 25-26 that we will be using agency ambulances essentially as a peak lopping? You will be able to see over time trends and where your peaks are. There'll be seasonalities, etc. So is that the intention, that post 25-26, once you have got back to the status quo, we hope, that you will, as a policy, only use agency ambulance for peak lopping? Thank you.
Difficult one to answer, because in some respects we will probably always have the need to have that capacity to be able to bring someone in that extreme that we need them. If we don't have the resource, can we get them from somewhere? But the plan is certainly to reduce the numbers and have more and more of our own people, as it were, but it will obviously take time. We generally know when the peaks are. They are fairly seasonal. But also even things like school holidays and things like that make a difference. So again, we know with all of the different regions, they all have slightly different school holidays. So we work around those. And often we find, again, one of the things that, going back to your point in terms of who wants to pick, some of them actually work for the private provider because they want the school holidays off. They want that time off with their children. So that's kind of worked into it. But the plan is, yes, we want to reduce them. Whether we will ever eliminate them completely, I would say is probably at this point unlikely, because it does give us that little bit of flex and room to sort of grow and squeeze as we need to.
Thank you.
Not really a question, just a comment. Councillor Whittle and myself, and I'm not sure if it was Councillor Bonham was there as well, but we had a health scrutiny meeting in the city last week. So I just want to congratulate you on the numbers and the reduction in the times. It was really impressive stuff. So I feel that we need to say well done as well, even when there are, you're doing well.
Absolutely. I think you're absolutely right. It's lovely to actually get good news coming through the system. And I suspect probably from an EMAS perspective, the organisation must be absolutely chuffed to bits that it's heading in the right direction.
Yes. And I will say thank you, because it's also a system. It's a system response, and we couldn't have done it, particularly without UHL's and the ICB's support to some extent. They have absolutely supported it. But yeah, it's helpful, because again, what we do find, again, when you look at the average, if we're hitting 35 minutes now, we need to be hitting under 20 to be able to get to that. So and yeah, no, it's been a bit of a hard slog for some of our staff, but it's encouraging.
Brilliant. Thank you very much, Susanna. Look, I like to end on a high note, and that's a high note, so thank you very much. Thank you very much for joining us. Thank you very much for bringing a very positive paper, and well done to all the organisation, and fingers crossed that the 18 minutes are there sooner rather than later. So thank you very much for bringing that to us. Thank you also very much to the rest of the committee. We only have one item left, which is item 11, date of the next meeting, which is the Monday, the 18th of December. As we have discovered from today's meeting, it's going to be a full agenda. So we look forward to that. But as always, we target the 2 hours because that's the, I think everyone's on top form at that point, as today has demonstrated. Some excellent questions. Thank you very much for all of you for participating. Meeting closed.